Good afternoon, everyone.
Good
In,
afternoon.
in last lecture, we studied about head injury. In today's lecture, we'll study about the management of head injury. As we saw in the last lecture, increase in head injury incidence is due to industrialization and increased incidence of the road traffic accidents. The problems due to causing the head injury and its increasing severity is due to lack of appropriate transportation and facilities, insufficient trained manpower, underdeveloped trauma care system, overall poor infrastructure of our healthcare system. As we saw in the last lecture, the types of head injury: scalp injury, skull fracture, brain injury, and vascular injury. The pathophysiology of the head injury is due to direct impact and the contricute injury, shearing injury, diffuse external injury, and due to secondary insults, as we saw in the last lecture. Degree of head injury is assessed by the GCS, that is Glasgow Coma Scale, and if the GCS is 13 to 15, it's relatively normal. If it's 9 to 12, then it's a moderate head injury, and if it's 3 to 8, it is severe head injury. The intracranial pressure is governed by the Monro-Kelly hypothesis, which is also called as Monro-Kelly doctrine. Basically, skull is a non-elastic enclosed compartment and there is a uniform pressure throughout the cranial cavity. The sum of the intracranial volume of the blood, brain and CSF and other contents in the skull is constant. It does not change. Any change in one component of the skull leads to decrease in the component of the other content, and that will compensate for the pressure change. If that doesn't happen, that will give rise to increase in the ICP. So increase in one component must offset by equal decrease in other component, else pressure will increase. The initial resuscitation should be when signs of transtentorial herniation or progressive neurologic deterioration not attributable to extracranial explanations are present. It should be assumed that intracranial hypertension is present and it should be treated aggressively, including hyperventilation, mannitol, and adequate volume resuscitation. Sedation and neuromuscular blockade can be useful during transportation of the head injury patient. The resuscitation of blood pressure and oxygenation should be the highest priority. The guidelines for the blood pressure is systolic blood pressure should always be more than 90 millimeter of mercury and hypoxia should be prevented. Apnea and cyanosis should not happen and that should be discouraged. Mean arterial pressure should be maintained more than 90 millimeter of mercury throughout the treatment to maintain the cerebral perfusion pressure of more than 70 millimeter of mercury. Else the brain will become ischemic and it will go into irreversible damage. The mean arterial pressure is calculated by the formula. It's the diastolic pressure plus one third of the pulse pressure. That gives rise to your mean arterial pressure. And cerebral perfusion pressure has a formula that is mean arterial pressure minus your intracranial pressure. Intracranial pressure monitoring system is there, and the guidelines for that, it should be done in severe head injury with abnormal CT scan on admission, or severe head injury, as you know, that is of GCS 3 to 8. Abnormal CT means with the hematoma or contusion or edema or compressed systems. Severe head injury. The second criteria for ICP monitoring is severe head injury with normal CT if two or more of the following features are present. That is, age is more than 40 years, and if there is unilateral or bilateral posturing of the patient, and it is not routinely indicated in mild or moderate head injury. There are various methods to monitor the ICP. The most convenient and common method used is the ventricular catheter, that is external ventricular drainage catheter, connected to the external measurement apparatus. It is the most accurate, low cost, and reliable technique for monitoring the ICP. The other methods for monitoring ICP include parenchymal ICP monitor, which is fiber optic, which can be placed in the subarachnoid space, subdural space, epidural monitors, but these are less accurate than neoventricular catheters. Hyperventilation should be done. Chronic prolonged hyperventilation therapy should be avoided in absence of increased ICP because it washes out your carbon dioxide level, that is your PaCO2, and it gives rise to another ischemic change. The guidelines use of prophylactic hyperventilation should be avoided. Hyperventilation therapy may be necessary for brief periods when there is acute neurologic deterioration or for longer periods if there is intracranial hypertension refractory to sedation or if there is paralysis. If CSF drainage is also not causing the decrease in the ICP and it is giving rise to the persistent drainage, then hyperventilation can be used intermittently. And if even the osmotic diuretics like mannitol is also not affecting the ICP, then hyperventilation can be used intermittently, but it should not be used continuously. Jugular venous oxygen saturation, arterial jugular venous oxygen content differences, and cerebral blood flow monitoring may be helpful when partial pressure of the carbon dioxide is less than 30 millimeter of mercury. Cerebral perfusion pressure should be maintained at a minimum of 70 millimeter of mercury. The clinical parameters for brain function and survival depends on cerebral perfusion pressure, and as I told, cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. So mean arterial pressure should be raised and ICP should be decreased so that you can maintain the cerebral perfusion pressure, and it should be maintained more than 70 millimeter of mercury. The use of steroids is not recommended for improving outcome or to decrease the ICP, and there is no known beneficial role. So, use of steroids should be discouraged. It should not be used in case of head injury. Uses of mannitol as a hyperosmolar therapy. It is effective for control of raised ICP after severe head injury. Intermittent boluses are more effective of mannitol than continuous infusion of it. The effective dose is 0.25 gram to 1.5 gram per kilogram. The indications for its use are prior to ICP monitoring are signs of the transtentorial herniation, which is assessed by looking at the pupil. If the pupils are of unequal size, then that means there is increased ICP, provided there is no congenital pupillary asymmetry, that should be ruled out. Or progressive neurological deterioration not attributable to systemic pathology, then that is due to the raised ICP, and mannitol's use is mandatory in that case. Serum osmolality during the mannitol therapy should be kept below 320 milliosmoles. Euvolemia should be maintained by fluid replacement, as mannitol is a diuretic and causes your decreased fluid level. Hollis catheter should be inserted if you are giving the mannitol therapy, as it is a diuretic. And head injury patient cannot go to the bathroom frequently, so he should be or she should be catheterized. High dose of barbiturates may be considered in hemodynamically stable, salvageable, severe head injury patients with intracranial hypertension refractory to maximal medical or surgical ICP lowering therapy. Barbiturate coma is a last resort, which indications for it are intractable intracranial hypertension. Barbiturate functions by decreasing the ICP and decreasing the cerebral metabolism. It also decreases the O2 used by the brain tissue, and it decreases the blood flow. Care of the nutritional support of the patient should be taken. 140% of the basal metabolic rate in non-paralyzed patients should be maintained, and 100% of the BMR in paralyzed patients should be maintained. 15% of the calorie should be given as a protein. And use of feeding via the gastrojejunostomy tube is preferable than your rice tube feeding, because it causes the static injury. As there is prolonged rice tube insertion, it may give rise to nasal sores and all those things. Prophylactic use of antiepileptic drugs is not recommended for prevention of the late post-traumatic seizures, but it is recommended as optional treatment to prevent the early post-traumatic seizures in patients at high risk for seizures following head injury. All patients with clinically severe head injury and those predisposed to early epilepsy with should be given phenytoin for at least 7 days. The dosage of phenytoin is 15 to 18 milligram per kilogram. First, you give the loading dose and followed by a maintenance dose that is calculated as 5 milligram per kilogram per day in divided doses. The infections should be taken care of. No antibiotic is needed for basilar skull fracture. Perioperative prophylactic IV antibiotic should be given. Single dose, 1 hour prior to cranial surgery, and 2 doses post-operative are sufficient. But as we see in our setup, there are high chances of the infection. So sometimes we continue giving antibiotics, but that should be discouraged. But for that thing, you should take all the aseptic precautions, and your environment must be of that sort to give only 2 doses post-operatively. But the standard practice should be of 2 doses post-operatively, and this practice is practiced by many institutes like AIMS, NIMANS, Sri Chitra institutes in neurosurgery setup I'm talking about. But in many other setups like the peripheral medical colleges, the antibiotic use is rampant, and that should be discouraged as it is giving rise to very, very resistant bugs, which we cannot control in the coming future if we use antibiotics rampantly. So that should be avoided. If drain is present, you have given the drain to the patient after surgery, then antibiotics should be continued. The metabolic care of the patient should be taken care of, as the most of the head injury patients are prone to develop the syndrome of inappropriate antidiuretic hormone secretion. In those patients, fluid restriction should be done to 1 liter per day, and high salt diet should be given, and if needed 3% sodium chloride infusion can be given. Hyperglycemia should be taken care well of with the insulin treatment if it is more than 200 milligrams per deciliter. So now, to summarize the head injury patient's management, what all should be done in a patient of a head injury? So the highlights are: avoid hypotension in a head injury patient, avoid hypoxia, maintain mean arterial pressure, that is diastolic plus one third of pulse pressure more than 90 millimeter of mercury, maintain cerebral perfusion pressure, which is mean arterial pressure minus one minus ICP, intracranial pressure should be more than 70 millimeter of mercury. ICP monitoring should be done in severely head injured patient. The best mode for this is intraventricular catheter. There is no benefit with the use of steroids in a head injury patient. Avoid prophylactic use of anticonvulsants, but if there is brain parenchymal injury, then anticonvulsant should be administered. Avoid prolonged or prophylactic hyperventilation. Mannitol is effective in control of intracranial hypertension, but it is effective if it is given in intermittent boluses. In that case, euvolemic status of the patient should be maintained, and avoid hyperosmolarity. The osmolarity of the blood should be less than 320 milliequivalents. The general measures should be taken for head injury patient: elevate the head end of the bed to 30 degrees, place the head in the midline position, avoid hypotension, use pressors that means hypertensive agents if required, maintain euvolemia, control severe hypertension, systemic hypertension. Mild sedation can be given if the patient is very much irritable. Normal ventilation should be given. Avoid prophylactic hyperventilation. Intubation is needed if the GCS score is less than 8 or patient is having any sort of respiratory distress. First and foremost thing that you should do is to intubate the patient. The first line therapy in managing the head injury patient is mannitol, mild hyperventilation, and CSF drainage. Second line therapy is hypothermia, moderate hyperventilation, high dose of barbiturates, and the last resort is decompressive craniotomy. If the pressure is very much high, you cut the bone out and you place that bone in the subcutaneous space in abdomen, and you make the space for brain to expand, and that is called as decompressive craniotomy, which may be needed if the ICP is not responding to any sort of medical management. So this is all about the management, and these last two slides are for you to assess the level of the consciousness. The first is the alert conscious, that is aware to the surrounding. Second is awake, that is well oriented but not aware of the surrounding. That is, patient is well oriented but he is not aware where he is or like that. Lethargic patient is can converse but he is drowsy. He is not knowing himself that what he is talking about. So that patient is called lethargic. Then stuporous, he is drowsy, he cannot speak to you, only moans and groans, and there is a repetition of the same type of words. That's called echolalia. Fifth type of the patient is the semi-comatose. If painful stimulus is given, he will only respond. And the sixth is comatose. He won't respond to any sort of pain stimulus. Coma has three stages. The first is the decortical rigidity. There is no cortical activity. The limbs are internally rotated, flexed hands and legs in response to painful stimulus. That's decorticate rigidity. In GCS scale, it's scale at the M3 response. And decerebrate rigidities, hands are extended, internally rotated, and legs are extended in response to pain. And on GCS scale, this response is scaled as M2, the motor 2 response. And non-responsiveness, there is no response to pain. If there is any question regarding the management of the head injury, you can ask me.
No, sir.
Thank you.